Hello, everyone. My name is Peter Pruyn, and I am delighted today to be joined by my EMDR colleague, Christie Coho. Welcome, Christie.
Hi, Peter. Thank you.
Um, Christie, I enjoy having guests introduce themselves because I always find I learn something about them. So, what would you like our audience to know about you?
I would like the audience to know that I'm really grateful to be here. And I feel like there are other people who are more experienced that could be here in my place. But I'm happy to have the opportunity and hopefully will do a faithful job to the people that I'm speaking about. Don't know. I'm an American by way of London for a long time, almost 20 years. Currently working to beat Brexit, being in Spain, hopefully about to make that happen on a permanent basis. So, yeah, life takes you really unexpected places.
Yes, it does.
Like working with the issue that we're going to be talking about today.
Yes. And before we get into that, I just want to mention to our audience that we certainly want them to take care of themselves in whatever way they need to in the course of listening to this conversation. Um, we're going to be talking about some tender things, and if you decide this isn't the conversation that you need to listen to today, that is absolutely fine. Christy, is there anything else you might want to add to that?
I will probably at times be using terms for different parts of the body, mostly around the genitalia, and I will use sort of medically appropriate, but also everyday language terms, if that makes sense.
Mhm.
Common terms that we would use for them, but sort of the sort of, yeah, appropriate terms for them.
Great. Thank you, Christy. So, to start us off, I'm wondering if you could just tell us something about your professional career in this field.
I definitely feel like it's been full of blessed with opportunities, and I think I'd really like to encourage people to set out on the path that seems like the path they want to go on, even if they're not sure how to get there, because opportunities may open up. So, very briefly, I trained as a social worker. I knew as a teenager somehow that I wanted to do therapy in a community context. So, went the psychology route. Got offered to do the doctorate, but decided to skip that because I just didn't like the real sort of individual focus on kind of the individual in this office space. Kind of, it just felt like it was just leaving so much context out. And my social work tutor kept saying, no, sorry, my psychology tutor kept saying, oh, you want to be a social worker? And I kept saying, no, I don't. But it turned out I did. So I've been a mental health social worker for many years now. And I actually haven't officially worked as a social worker for quite some years now, but I retain the title both here and in England, sorry, in the US and in England, because it's really important to me to kind of practice in the way that I was trained as a social worker. So I then became a licensed clinical social worker in California, which means a therapist. Although I would say I still mostly did social work kind of stuff, but with a lot of clinical bits to it. So mental health with young adults mostly. And then had long had a dream of traipsing off to Europe, which I managed to do by being a social worker. So that got me hired in London. And I worked in community mental health in London. And then through the mental health, the public mental health system there, I was able to train formally as a cognitive behavioral therapist. So that got me back into the world of therapy, which I was really pleased about. And then from there, just sort of, I guess I sort of kept thinking about, what do I want to do? And trauma became an area of real interest. And I kept expressing that to my bosses, and we kind of found little ways for me to do more and more of that. A partner service opened up that was for refugees with post-traumatic stress disorder. And so then I was able to go do what's called a secondment. So I was able to work part-time there doing maternity fill, and then somebody filled my post at the other job. And yeah, just Really loved that. Got trained in some different trauma-focused therapies there, narrative exposure therapy, and already had the CBT on board and things like that. And really wanted to keep working for them, but the funding, as often happens, kept running out. And then one day they said, "Oh, we have this job for you, and it'd be perfect, and it would be in a multidisciplinary team." Um, but they were kind of skirting what it was. So eventually I said, what is this thing you're talking about? And they said, well, it'd be working with pregnant women who've experienced female genital mutilation in a maternity clinic, and you'd be the therapist there. And I was like, great. And then I thought, I have no idea what to do. So that was how I got linked to this. I don't want to call it an issue, but this life experience that many women have called female genital mutilation or cutting. I'll come on to that in a minute. And then I went and worked at another other sister service of that same public health service I was working in, and got an opportunity very unexpectedly there to get trained as an EMDR therapist, which I had wanted to do for a very long time. So yeah, happily I've been practicing EMDR, too many acronyms, EMDR since 2018, I think.
Yeah. Wow. Thank you for that. I did not know all that. Wonderful to hear about, your journey. Um, so let's go ahead into the topic, just in very simple terms. Can you just define for us what is female genital mutilation cutting?
I think at its most distilled, you could say that it is the altering of a part or parts of the female genitalia, the external genitalia, that serves no health or medical function, as in the procedure of whatever it is that you're doing to that body part doesn't serve any function.
Mhm. And can you help me understand why is it important to make a distinction between mutilation and cutting?
Well, so many practicing cultures call it, groups of people call it cutting or sometimes circumcision. That's how it would be translated into English. I mean, some actually use those English terms if English is a spoken language in that community, but there are literally lists of words in all sorts of different languages, but they often translate to things like cutting or circumcision.
Mhm.
Um, or sometimes things like the requirement, because communities have thought that it was a religious requirement, that sort of thing. Um, so then, but I believe the late 70s, the World Health Organization chose to call it female genital mutilation. And some of the people who kind of brought forward that idea were saying, basically, we want to make a distinction between some quaint cultural practice that exists and this, what is called a cultural practice, yet causes lots of harm to many people who undergo it.
Yes.
Um, I'd say the language now comes back around where many people aren't comfortable with mutilation for various reasons. And again, many women who've experienced it, they don't call it that. So even if they're talking in English, they wouldn't call it that. And so they often say cutting or circumcision. So the C can be cutting or circumcision. And if I can just also say, I think it is something that's worth considering, because if, like, very briefly as a therapist, if we think about, if we label something as domestic abuse or child abuse to a client, we may often experience that that's not how they think of it. And it may be that it takes some time for them to come around to decide if they agree with that definition or not, which often they do, unfortunately. I mean, unfortunately, because that's what happened to them. Um, Mutilation is a very difficult thing to think about, that having happened to my body. And that's how other people are going to describe my body, or how I'm going to describe my body to myself. For some people, they really appreciate that term. Like for some survivors, they appreciate that term because they know that people are taking that seriously and recognizing the impacts that they've experienced from it. For many other people, it feels shaming or embarrassing or making them feel less than. So, tricky terminology.
Yeah, well, I'm really glad I asked the question, and
Mm,
your
mm,
answer really speaks to the importance of having the work being client-centered.
Mm,
So I
absolutely.
wonder if we could go back to how you first encountered FGMC. Sounded like it was in this job that you were invited to work for.
Mm.
Um, can you just tell us a little bit about what that was like for you, your first exposure to this?
Sure. So my first exposure was actually a number of years earlier. I've been a really active member in some Amnesty International groups, and we used to do campaigning to various governments to advocate that they uh, basically didn't allow the practice, that they would outlaw the practice in their country. So I thought I knew what it was about. And then when it was the case of go sit in a room with the client and talk with the client about this life experience that they've had, it felt very different for me. And I definitely felt very unprepared, because it was a new job and nobody quite knew what to do with me. Even the people who had thought it would be a very good idea to have a therapist on this team, but they didn't really know what I should be doing. So I had the rare fortune of having a bit of time to prepare myself. So I did a bunch of reading around the internet and trying to find, kind of professional journal articles about FGM and mental health, which were quite few and far between at the time. Most of the FGM literature is under obstetrics and gynecology in the Western world, because that's kind of where the Western world intersects with FGM, or runs literally runs into FGM, is typically in maternity services, because there are ways in which FGM can impact the health risks of a woman who's potentially going to give birth.
Hmm. Okay.
Yeah.
Um, so I'm struck by, you being put in this position, uh, feeling you need to learn more, looking out for resources and learning, particularly on the mental health side of this, and
Mm,
finding that there's a there's a paucity of things to learn from. Um,
mm,
and that's one of the reasons why I wanted to have this conversation with you, because I do feel like there's so much stigma associated with the topic that it just isn't talked about, and it isn't
yeah.
also researched enough, particularly from the mental health side of things.
Mm.
So, just generally, what do you wish the general public knew about female genital mutilation cutting?
So I think, very much mirroring what you're saying, I wish more people knew it existed, because I think, yeah, the more people that know it exists, I think, like any issue of concern, some people will really kind of take that up personally and do advocacy in whatever ways they do advocacy around it. And the more people that know about it and feel that it's harmful to people, the more they can encourage other groups of people who are practicing it to find other things to practice. Anyway, there's debates around every word that gets used, including practice. Is it something that people practice, or no, it's just child abuse? We don't talk about practicing child abuse. And so if FGM is child abuse, which I would argue it is, and I'm not the first, many people would argue that it is, again, in, I don't know, Western context, we don't talk about, oh, parents practicing child abuse. Do you know what I mean? So it's this carrying on this idea of it being a cultural practice that is one of the barriers to people saying, oh, well, that's not my culture, that doesn't happen to people I know, that's not in, that's kind of not in my little universe. But I think many people feel concerned that there are children there that are abused, however they are abused, whether or not they know a child that is personally being abused. Do you know what I mean? Socially, societally, generally, we think, child abuse, bad idea. Violence against women, generally speaking, bad idea. You know, but FGM sort of gets siloed off in many, many ways. But in this context, it sort of gets siloed off as this sort of separate cultural practice. But in fact, if it's child abuse, then let's treat it like all other child abuse.
Mhm. Yeah, so I feel like you're speaking to my growing sense of one of the challenges of taking this issue on is that it has this duality about it that sometimes people position it as, cultural, with the implication that, um, no one should try to change it. And then
Mm.
you could equally position it as outright abuse. And that just seems really complicated for the therapist then stepping into a space with someone.
Mm, mm. Right, because every client who's experienced it is going to obviously have had their own experience of it, their own impacts of it. They're going to have their own way of thinking about it. They're the group of people in the family that they come from are going to have their own way of thinking about it. They may or may not still think of it in the same way that their groups of origin think about it or not. So
Mhm.
yeah,
Yeah.
multi-layered.
So, based on your experience, what advice would you give psychotherapists who are working with FGM survivors?
Uh, well, one thing which I think also relates to something that I'd like the public to know is also just the numbers, because I know you can sort of throw numbers out for anything, but the current estimates have gone up by 30 million since the last time there was an estimate. So the rates are overall are supposedly decreasing. However, there are more females being born, and COVID-19, that whole period of time, saw a rise in people being cut, because I think a lot of the health and even law enforcement groups that were kind of keeping an eye on people reducing the practice of FGM suddenly weren't around. So in the same way that we know that domestic violence rates went up loads during COVID-19, so did this form of violence against women. So current estimates are 230 million women alive today have experienced FGM. And every year there are about 4.3 million girls, typically girls, sometimes adult women, at risk of experiencing it. So that's 5.6% roughly of the world's population. So
Oh,
if this was practiced across the globe, I could say, think of 40 women you know, and at least two of them will have been cut.
wow.
So,
That is
yeah,
stunning. Wow.
it is staggering, which is why I think it's worth sharing, because it's, you know, literally a significant percentage of the entire world's population.
And correct me if I'm wrong, but one of the reasons I was prompted to want to do this with you is that, and correct me if I'm wrong if this is the right statistic, but in the city of London, I think, wasn't it 1 or 2% of women who were affected?
Uh, mm, it could, it wouldn't be quite that high.
Okay.
But there are certain boroughs, so certain regions of the city where yes, that would be true. I can think of at least three
Yeah.
where that would definitely be true. Yeah.
And that was really striking to me because I think some people would think of, a Western city like London as
Mm,
not being a place where you encounter this issue. But as
mm.
you're talking about it, it makes quite clear why it's actually everywhere.
And it is everywhere because of migration. It is everywhere, and it happens. And you know, there are still practicing families and communities, even amongst mm, the immigrant or migrant populations in many, in the U.S., in Canada, in the U.K., in many Western Europe countries. You don't have it quite as much in South America, but there it is there. There also happen to be two groups of indigenous people in South America who just out of their own idea practice it.
Hmm.
Um,
I
so
did
yeah,
not know
not
that.
not because it's been carried in from other people, but just they also thought of it the way other populations thought of it. So
Wow,
anyway,
I did not know that.
yeah. So yeah.
Okay. So getting into the possibilities of psychotherapeutic support for FGM
Yes.
survivors, in your
Yeah.
experience, what would you say are some of the common barriers to treatment for survivors?
I think that therapists and health professionals don't know what FGM is or don't know enough about it. They might have sort of just a faint idea. that therapists and health professionals are scared of it, averse to dealing with it. Another real barrier is that therapists and health professionals communicate, whether verbally or non-verbally, a lot of reactions when it's disclosed, or if I don't know, if a client says I was cut or I had what you call FGM, and then the therapist asks some more questions about that, and if the client kind of discloses a bit of what happened to them, or even what the practice is, there are many clients who have faced reactions that basically of disgust, of horror, of overwhelm, therapists literally crying when being told about this, all sorts of ways that I think professionally we would normally not respond to things. As I was saying earlier, in the obstetrics and gynecology literature, which has much more accounts than other kinds of literature of women's experiences with it. I mean, sadly, there are scores and scores of reports in that literature of women, describing all sorts of really terrible reactions that doctors and nurses and midwives had in front of the woman when they saw their vulva, or when the birthing started happening and nobody had looked at the woman's vulva until then and realized that it wasn't big enough to be able to birth a baby, and all sorts of things, and just things that make people feel completely like freaks and that they have something to be ashamed of.
Wow.
Yeah.
Wow.
Yeah.
That is sad.
Yeah. And I think another real barrier related to that is therapists not being comfortable talking about the things that may be involved. It depends on your client, but that may be involved in talking about with FGM. So that may involve talking about genitalia. It may involve talking about parents making a decision that they made at the time. And it's important that the therapist neither demonizes the parents nor sort of, I don't want to say apologizes for the parents, but sort of apologizes for the parents, kind of they were doing what they thought was in your best interest, which may entirely have been true, but that may not be what your client needs to hear, you know. I think as a therapist, if you're trying to wrap your head around it whilst you're in the room with the client, I think you need to be particularly careful about what you're saying. But it does seem to be an area, and I imagine that the same can often happen with a therapist, perhaps with sexual violence as well, that we need to be able to use direct, common, appropriate language, appropriate questions, invite the client to ask rather than making them feel like they have to tell us what happened, but just sort of approaching it in a mature way. And I'm not saying that in a condescending way, but I think that the sort of shock that therapists can feel kind of gets the better of them and overrides their hopefully typical kind of professional way of working with the client, or communicating with the client is what I would say. Yeah.
Gosh, that is just so important for our profession to hear, and makes me, again, grateful that you were willing to have this conversation with me. I hope it can make a difference to many providers. The other thing I was thinking about as I was listening to you is you saying that the first position you had was, correct me if I'm wrong, in a maternity organization, and that very often that's the first time some of these a healthcare provider sees these women and can just notice that FGM was done. And so it just strikes me that, as with many kinds of trauma, the average person does not seek out a trauma therapist, do they?
Very true. Very true. So I actually ended up doing ongoing therapy with very few women in that clinic, because that wasn't what they were coming for. Many of the women basically there's a process in most of the UK hospitals that if a woman, that midwives are meant to ask all women in a variety of ways if they've experienced FGM, to try to catch everybody. So not to say, oh, have you had FGM? Because that may or may not mean anything, or even to say, have you experienced female genital mutilation? I mean, for some women, they'll say yes, and for some, they'll say no, even though if you ask them, oh, were you cut when you were young, or have you been circumcised, or things like that, are you aware that you've ever had any sort of procedures done on your genitalia when you were young that wasn't for a medical reason, or lots of other girls in your community also had it done. Those are ways of asking that you might get a correct yes to, as opposed to just saying, did you have FGM? And you get a no, which is a false no. So, sorry, I lost my train of thought. So the midwives are all trained to ask that, and then any of the women who have experienced that then get asked to go to the FGM clinic. So again, they're not even asking to go to that in the first place, but they are asked to go, and this multidisciplinary team was set up in an existing FGM. So there was already like an FGM clinic within a number of the hospitals, particularly in London and other parts of the UK. And so it was a team of a specialist social worker who really knew about FGM, who really took the approach of, we want to support the women and the families, not that we want to condemn them and talk about what a big risk they are because maybe they're going to have their daughters cut. Yes, that's part of an assessment that we all needed to do, but that was not the social worker's, that wasn't sort of her driving motivation. It was these mothers to be are, or maybe already mothers, are people who had this probably difficult life experience. I mean, it would have been difficult in the moment, but it may or may not be having lasting impacts for this mother or mother to be. And so let's support them and support the family, and let's support the family to help ensure that the next generation isn't cut, as opposed to kind of going in and taking the kids away, which happens in some areas, but anyway, that's yet another barrier that we won't get into. And then there was myself as a therapist, and then there were also 2 health advocates. So they were trained around issues of FGM and in engaging women to come into the clinic and to get services. They also would engage them to try to help them get smear tests or other gynecological things that they maybe hadn't got up to that point. Sometimes because of the trauma that they had from FGM meant that they would have flashbacks or real tensions or fear of pain anytime things related to their genitalia came into the picture. And so they avoid gynecologists, they might avoid sex, all sorts of things. Doesn't mean they don't have sex, but they might avoid sex in general. Anyway, and they also did interpreting work. So they each spoke a language that was relevant to the particular kind of FGM affected community in the part of London that we were working in. So yeah, and obviously a specialist midwife who knew about FGM and had been working with that for a long time, who also happened to be from, I guess you could call it an FGM practicing country. So I think that also really helped lend a good bit of legitimacy for the women who came in. So yeah.
So you're really helping me understand the complexity of the landscape of this issue because, the picture you're painting is that there's a stark difference between experiencing a trauma that society views as a trauma, like having a car accident. You're not supposed to have a car accident. And so when you have a car accident, it makes sense to go get help for it. But if you experience a trauma that has been normalized in your culture, then that's really hard to step outside of to think about in terms of getting treatment.
Yes, and that's part of why it's also been difficult to eradicate this form of violence, because it's not seen as violence by the people practicing it, and then the people coming in, even if they are from within the same community, if they, let's say, have been convinced that it's not a good idea anymore and they choose to do advocacy within their community, that's the first really huge barrier that you face, is that the group in general sees it as actually as a positive thing. um,
Yeah.
or at a minimum, a necessary thing, sort of culturally or religiously or otherwise necessary. So yeah, it's a lot. It's a lot of levels at which to fight. I mean, Gambia has outlawed FGM and nearly unoutlawed it um, this year because a lot of the people at many different levels of government, all the way down to individual families, think that it's still a positive thing to do. And so they almost unoutlawed it, but at the very end, they didn't unoutlaw it. But it probably gives you a sense of how much those laws are being enforced and so forth in that particular country. So, yeah.
Yeah. So again, the picture you're painting suggests that for trauma therapists working with an FGM survivor, how important it is that that therapist is able to take in the complexity of where the
Mm-hmm.
person is coming from and really double down on meeting them where they're at in terms of their conception of what happened to them.
Mm-hmm. Yeah. Because you might also have a woman who comes from a community where, although this happens, it's never really spoken of. It's done because it's believed that it helps a woman to be clean and therefore more marriageable. And so to talk about other things, like literally to talk about sex, to talk about genitalia, to talk about things like that is very not okay. So, I've sat in an office in London trying to have a conversation with a woman about FGM and her saying, every time you say one of those body parts, I just want to do this because it's so against what feels okay for me, and so yeah, as you said, kind of really, I like how you said doubling down on really meeting the client with where they're at is super important,
Yeah.
yeah. It's
Um,
as individual an experience as any other experience. You said, you could have 10 people who experience car accidents, and that that's going to be a different piece of work with each of those 10 different clients. And
yes.
FGM is certainly no different. And so I think that's something we need to bear in mind, that it's almost easier to keep it as this big dramatic overwhelming thing, because then we can kind of distance ourselves from it a bit, just like, oh, that terrible thing that's practiced over there. Barbaric is a word that's used a lot, that's still used in the media a lot, and I just think it's so unhelpful, because again, who wants to think, oh, my community practices something barbaric, or like, you're not going to feel like those people are understanding you, and so you're not going to listen to that. Or again, thinking about something barbaric happened to my body. I mean, again, some women will appreciate the intensity of that word because they will feel heard and understood by it. But there's an awful lot of girls and women that aren't going to appreciate that, and they're going to find that very condescending. Another fact that I think is always useful to bring up about FGM in this kind of context is FGM was practiced in the US and in the UK very much by white middle class people in the 1800s. There were medical doctors and psychiatrists, I'm pre psychiatrists, I guess, who believed that the fabulous neuroses, which I think was just women expressing an emotional landscape. That's how I would describe neuroses. And nymphomania, which I would generally, looking back, describe as women having a libido, and them expressing that or doing something about that. That was then called nymphomania. So, yes, a clitoridectomy, which is where parts of the external part of the clitoris are surgically removed, was considered to be a helpful thing for neuroses and for nymphomania in the 1800s. Perfectly respectable white middle upper class women, or middle class women. So we need to not be on our high horses about these practices. So, because
Wow.
they're just things that human beings do to other human beings. I think
Wow.
it's
No,
important to keep that focus.
I never knew that.
Oh, I know.
Wow. So, what I'd like to do now is just change course a little bit and focus on an approach to psychotherapy that you and I are trained in, which is EMDR.
Mm-hmm.
And I'm wondering, I'm just curious, how do you explain what EMDR is to some of the clients? I'm really curious.
I figured you were going to ask me that question, but I was kind of hoping you wouldn't because it's a terrible thing to have to explain. I often start by saying it's going to sound very weird and woolly, but just go with me. Uh, so I try to explain it as it's there are many kinds of psychological therapies that try to help people recover from trauma. EMDR is one of those. EMDR is also very helpful for other kinds of psychological distress and actually emotional distress or even physical distress, as you well know from the work that you do with women's health. And it is a way of trying to engage our whole internal system so that our internal system can work together to do healing. Something I learned in EMDR training that I thought was really helpful as a concept is that psychologically we have the ability to heal in the same way that physically we do. So if we get a cut, you don't have to sit there and tell your hand how to heal that cut. And nor do we have to sit around and tell ourselves how to heal from every single sort of emotional or psychological injury that we experience, in life. If we did, we wouldn't be doing much other than that, I think, because humans have an inadvertent way of really hurting each other a lot. So,
Nice.
uh, so this kind of therapy is a little bit different in that it is more of a body mind therapy and it brings the body in, including by using what's called bilateral stimulation. So a left right movement or sound or following or a physical touch, which seems to help get both hemispheres of the brain really activated. It also really taxes our working memory, and that is helpful in basically in changing the narrative. So if we're repeating a traumatic memory to ourselves in the same way that we always repeat it, it's going to stay that way. And if we start introducing other elements, which might be, let's just take a fraction of that memory and focus in on a tiny bit of it, which is what EMDR does. Or let's add some tapping, or let's add some lights to follow, or following the therapist's finger. That's the sort of traditional eye movement of EMDR. And we allow that seems to sort of open up doors within us to allow kind of newer, healthier beliefs and ideas, and even just more mature ones through life experience to connect up with ideas and beliefs that we're holding from the trauma, or even physical things we're holding in our body from the trauma that have just kind of been stuck in that frozen state. And so it kind of connects it all up and sort of brings it along up into the current time. And the last thing I'm going to say about it is that what I love about it is that it just helps. It helps those experiences and our beliefs about ourselves sit differently in us. And again, that's a bit woolly. I can't really explain it better than that. But every single client that I've done EMDR with would say that, like, oh, that's just different now. I think about it, and I think about it differently now, and I feel differently about it now.
Nice. Well, as I've been listening to you, Christy, I'm realizing that being an EMDR therapist working with an FGM survivor, I feel like there are just multiple barriers to understanding that you need to bridge. I mean, correct me if I'm wrong, but I would imagine that, I mean, you've already talked about how many FGM survivors um, grow up in a culture where there's stigma around talking about sexuality in general.
Mm,
Then there may not be a recognition that there's anything wrong with FGM.
mhm,
Correct me if I'm wrong, but I'm guessing psychotherapy probably isn't normalized in many of these cultures.
mm.
And you, as the EMDR therapist, you have to take on all of that.
Yes, yes. And I would say, I suppose, I'm also seeing women in Western countries. So people who are now living in Western cultures, they may have been living there for a long time or a short time. That is often, just very briefly, that's often the process through which women do come to start viewing FGM differently, because they're living now in a society where the majority aren't cut, and it's somewhere along the way they find that out. um,
Mhm.
I mean, some already knew that, some didn't know that, but there are many women who kind of assumed, I guess, that, sorry, I'm not saying I guess because I think that like they've said that, they've assumed that most women were cut. And then they find out that like, oh, the women weren't cut and it's seen differently. Being cut is seen differently, but also just kind of women and sex and sexuality is seen differently as well. And so so that also then adds all sorts of other layers to the complexity, because now they've kind of got this disparity between how they're seeing it as an adult, not just because they're an adult, but because now they're an adult living in another culture with another option of a way of looking at that experience and looking at that community that they're from that continues to do this, continues to have their girls experience this experience.
Yeah.
So and that's often things that do bring women into therapy. So very interestingly, in the FGM maternity service, sorry, sorry.
Take your time.
Oh no, my cough has caught up with me. One moment.
Take your time.
So in the FGM maternity clinics, women often didn't take up therapy. But when the public health system started opening up clinics for non-pregnant women, almost every woman who came in wanted to have sessions with me. And I'm still in touch with many of the clinics and the therapists in those clinics. And many of them say that the vast majority of women who come to the clinic either come for psychological therapy, or when they're offered it, immediately take it up readily.
Wow. Wow.
So it was quite interesting. Again, the pregnant women often didn't take it up because they're pregnant, they had other things going on. They were also working, many of them also already had children. They knew they weren't going to be able to continue it once the baby came, et cetera, et cetera, et cetera. Mm-hmm. As in, they didn't figure they would have time, not because we wouldn't offer it to them, but because they didn't figure they'd have time. So
right.
There were all sorts of practical reasons.
Yes. Okay. So given all that complexity and also acknowledging that every survivor is going to be different, is there any general advice you might want to give to the EMDR community about using EMDR with FGM survivors?
I think I would say that it's the same as, I think I would say approach it like you would approach someone who came for child abuse, or someone who came because they said, I can see that there's a lot of trouble in the family, or I have a lot in the way we relate to each other, or I have a lot of anger at my mother or father or other parents, and work with those issues, because those are the issues that the women are coming with at the time. The source might be a bit different and certainly has its own layers of complexity to it, but you'll get into all of those. But in a way, I would do the same as what I would do with any other client who had child abuse, or female client who had actually clients of any gender who had sexual violence. So, and again, that's another whole rabbit hole to go down. Is FGM sexual violence? Some people would say yes, because it happens to the person's genitalia. Other people would say no, because that's not at all the intention of it. It's around ideas of actually making that part of the body better, or cleaner, or healthier, or sort of holier, or whatever. But so anyway, so in a way, almost like don't try to unravel all of the complexities at the beginning. Take the client as you would any other client, and listen to what they're saying, listen to what they're coming in with, listen to what they're feeling they want to work on, doesn't mean that we don't sometimes propose things. Like, again, sometimes we might use a term like domestic abuse or domestic violence or abuse, and then kind of sit with the client with that, and kind of sit with them as they decide what they think about that.
Mhm. Yep. And so what I'm hearing you say is just underscoring this theme of complexity that, you know, someone, an FGM survivor is willing to work with a psychotherapist. There's their individual experience. There's the family that surrounded them. There's the culture that surrounds their family. Um, and all of that is in play. And I think EMDR therapists might be trained to focus on coming up with a trauma list, uh,
Mm.
and thinking about, okay, we're going to process, the memory of the cutting and, some other things. But actually, what you're underscoring is just way more complex than a trauma list.
Mm, could be, could
Could
be,
be, could be.
definitely. I think where the complexity might come might be in the present column and maybe the future column of the case formulation. So in EMDR, we do in some ways a very simple, useful case formulation where we kind of have a what happened in the past that we think we need to work on. How is that impacting you in the present and the future? So I would say that present column is probably where the vast majority of the complexity is, because it's how does the woman think about it now? Perhaps that's different than how they used to think about it. Maybe there's stuff in there about their sexuality or their sexual identity or their sense of sexuality of themselves as a sexual being. Uh, they may also not have it. They may not bring sexuality into it at all. I mean, it's also really important to remember that, like with any trauma, it's got its list of potential impacts, and no one survivor of that trauma is going to have that whole list. So FGM sadly does have very long sort of physical, emotional, psychological, relational lists of potential negative impacts, but nobody's going to have all of those, and certainly not all at one specific moment of their life. So I guess it's about, yeah, um, yeah, you can in fact identify the memories, and the parts of the experiences, and I have done that with women. And yeah, the present column is often quite full of, of impacts and beliefs about themselves or beliefs about the world that need to be um, recovered from, reprocessed,
Yes.
shifted.
Yeah,
Yeah.
that makes sense. I'm so glad you laid
Mm.
it out in that way. Um, so again, I'm just really struck by the layers of complexity that you've articulated, and combined with the stigma that it isn't talked about as much as it should be for a whole host of reasons.
Mm.
So I guess I just also wanted to give you space in light of everything you've talked about. Is there some aspect of FGM that you don't usually get to talk about that you would like to talk about?
Hmm. I I don't get to talk about it that much at all. So I guess I'd like genuinely I'm grateful to have this opportunity to talk about it. I mean, my colleagues in every service that I've been in, they know that I know about FGM. So because I'll talk about it with them, and my friends all know, and things like that. But yeah, tricky, is that something one brings up in party conversation, or not? I do, but not at every party I go to, just for the record. But if there's an opening, I won't shy away from it. But no, I don't know that there's anything specific, because I really do think that for most people, it's like quite such an unknown, and not like I even thought, like I said before, I did this work, like I kind of thought I knew about it, from kind of the limited advocacy work that I'd done around it in Amnesty. And then it's just like, oh, like, I knew like a 1,000th of of what there is to know about it at the time. And again, that's not said to whelm people, because it's also not like, oh, if you have a client who has FGM, like you must go out and learn all of this stuff about it, because like loads of it's not going to be relevant to the client. Like, do you stay with what the client is bringing in, and I think do educate yourself. And I don't think that that's necessarily different advice that I would give for lots of things. I mean, if I don't know, if a client came in and they were had been affected as a child by like ritual religious based abuse, like sure, that's something I kind of know about, but not really, and it's not my client's responsibility to educate me about that life experience that they've had, but I'm going to be much better equipped as a therapist if I, if I in between sessions do a bit of educating myself about like, okay, exactly what is this and how does it work and who practices it and why, and getting a rough sense around the issue, and then coming back, and then bit by bit, depending on the client's pace, I can kind of say, I have this understanding about it. Is this part of your experience or not part of your experience? And how do you understand that? And things like that. So, I mean, there are these, sort of life experiences that do have a label on them because enough people experience them. Categories is what I was trying to say. That I do think we can do better therapy with people if we do, educate ourselves a bit.
Yeah.
Yeah.
I mean, the main thing I take from that is that we somehow need to figure out ways to create more healthy conversations about FGM.
Mm.
And as I listen to you, two come to mind from my own experience. Um, First, I had the opportunity to attend um, the Committee on Status of Women meeting at the United Nations a year or so ago, and there was just one session on FGM.
Mm.
And the thing that I was really impressed by was, and there were maybe 40 or 50 people in this conference room. The thing that I was impressed by was, on the one hand, it's a horrific topic in many ways, but I just wanted to share with you and the audience that I think there was a really palpable sense of what the word is, engagement, optimism. We're in this together in this space. That was, one of the few spaces in the world where a whole bunch of people would come together who are really concerned about this and really wanting to make a difference.
Mm.
And there was a very unique kind of energy
Mm.
because of that. And I've never forgotten that, that
Mm.
these conversations don't have to be, feel like a wet blanket. That
No.
that there really can be a sense of hope and healing. I've
Mm.
never forgotten that. And
Yeah.
then on a much smaller level, but similar, thanks to you, now on my intake form, which lists a number of common trauma symptoms and asks people to rate them, I've added a question about female genital mutilation cutting.
Mm.
And I really appreciated your suggestion because as I listen to you, you know, I think one of the things that does is it sends a signal to the client that this topic is okay to talk about here.
Mm. Mm.
And it requires the therapist to have done at least some homework to realize, oh, yes, that is worth putting on there. So I just wanted to
Mm.
thank you for that.
Well, thank you for doing that, and it's been a good reminder to me to practice what I preach, which is, when I do staff trainings and stuff, I always say to people, ask every woman, And actually, I also think it's a good, I'm speaking as a white therapist, I think it's a good non-racist practice as well, to like, let's get out of this idea of like everyone who's experienced FGM is from a sub-Saharan African country. Like that is not the case. There are women who look of all sorts of different kinds and ways. And it is, it's practiced as in it's been a long-term practice in scores of countries across the world, including outside of Africa. And now because of, again, not just migration, but intermarriage and people moving to other countries for business reasons and whatever, like there's all sorts of reasons why there may now be women who look all sorts of different ways who've experienced FGM. And I agree with you. I think it's better to ask. And even if it turns out that the majority of our clients say no, there might be one woman who's really glad that you asked, because she did, and she wouldn't have thought to bring it up, much like you've described other women when you've asked them about other female health issues that they've had, and they say, oh, I wouldn't have even thought to bring it up here. Or maybe not thought to bring it up because you're a male therapist, but
Exactly.
So yeah.
Thank you, Christie. Well, this has been, gosh, beyond what I'd hoped for in this conversation. I'm just so grateful to you. Now it's my turn to take a drink. And now we come to what I find my favorite question. When someone has talked about something very complicated like this, and there are things that we'd like to change, but it is complicated. So if you woke up tomorrow and discovered that you had been made queen of the world, what might be one of your first acts?
Well, probably in context, my first instinct would be to say, to just completely eradicate FGM. However, I'm going to go bigger than that. I'm going to say one of my first acts would be to eliminate violence by any one person or group of people against any other human being. And then maybe I'd retire.
No, I think we need you to stay in.
My work is done. My work is done.
I think we need you to stay in that position a little longer. I mean, it's also useful because I feel like one of the things you're doing with that comment is you are squarely positioning FGM as violence.
Which means that everybody needs to be involved in eliminating it. It is equally important for men and boys to be involved in understanding it, knowing about it, being able to talk about it amongst other men and boys and amongst women. In as far as that's culturally appropriate, but particularly in spaces where maybe it wouldn't be seen to be as appropriate for them to be talking in an intergender way, then it's probably all the more important that men and boys can talk to other men and boys about that not continuing, because everybody's involved in it continuing. So everybody needs to be involved in it not continuing.
I'm so glad you said that. So once again, Christie, this has been such a rich conversation for me. I've learned so much. I hope other EMDR therapists and therapists in general and survivors learn something from this. And so thank you for being willing to have this conversation. And as you know, one of the things I like to do is to give my guests the last word. So how would you like us to end our conversation?
I'm quite happy with my queen my queen powers.
That's good.
Actually, although I don't know if you put. I think I am going to say if you do put links in with your videos.
Absolutely.
Okay, so we can put a link into the FGM therapy guidelines, which are free. So that's not me doing a self promo. But I was involved with some other therapists when other therapists were also saying, where is the information about this that we need as therapists to be working with these women who are now showing up at our therapy services? There was sort of none to be found. And so we wrote some off of our limited experience, but also in conjunction with therapists and organizations who have more experience, much more experience than a few of us did. There's also a psychosexual therapist who has included in the trainings that she gives, has included at least a little bit about FGM for decades and decades. So we brought her in on the project as well. And anyway, it's free, it's online. It requires a revision to really help kind of culturally and sociopolitically contextualize it. But we were trying to do an almost dry version, if you can believe it, of guidelines, just to make it as straightforward as possible for therapists to sort of not scare them off of all of this complexity. But anyway, someday we'll have sort of a contextualized version out there. But anyway, if it's helpful to people, yeah, there's more information in that.
Beautiful. I'm so glad you mentioned it. And yes, let's have a back and forth about what links and resources you'd like to include. So I can put that in the comments, and I'm absolutely delighted to do that.
Great, good.
All right, Christie, again, I can't thank you enough. This has been an incredibly rich conversation, and
Well,
let's stay in touch.
thank you. Genuinely, really, really appreciate it for the opportunity. So thank you so much.
All right, Christie, take care.
Take care. Bye.